Opioids are highly addictive, morphine-like drugs used to control pain. Some are long-acting, like oxycodone, some are synthetic and pretty potent, like fentanyl, and there are others, like tramadol. We in Australia have not experienced the opioid disaster the United States has, which some say has in the US reversed life expectancy gains due to the huge numbers of overdose deaths. Australia has had its problems though, and certainly experienced the unethical and unscientific promotion of these drugs by some pharmaceutical companies. Some of you might have seen Dopesick on Netflix. Hospitals are often where opioid use begins, being prescribed for acute pain following surgery, for example. Last week, the Australian Commission on Safety and Quality in Healthcare released standards on what should be expected with opioid use. Pain medicine specialist Dr. Chris Hayes chaired the group that developed the standards. Welcome to the Health Report, Chris.
Norman, thank you. Good to be here, although slightly alarmed by the content of your previous speaker's word on bats and viruses.
Yeah, well, you don't come to the Health Report for succour, Chris. We just panic. Panic is our coin. How big a problem is this?
As you say, a smaller problem than it was in the States, nevertheless substantial. Our rate of opioid-related deaths in Australia has been very similar to the rate of deaths from car crashes in recent years, that being up over 1,000 deaths per year. So a substantial problem, and there are other harms of less severe nature than death. So certainly in the healthcare sector and at government level, there has been greater regulation in the opioid space because of the deaths and other side effects.
So one of the aspects of regulation is that you can't buy opioid-linked analgesics over the counter anymore. You've got to get a prescription from your doctor. But you're focusing on the hospital system, aren't you, in this standard?
Yes, that's right. I mean, as you point out, the focus over the last few years of regulation has been more on primary care and GPs. And this clinical care standard changes to focus on the hospital system, particularly the inpatient wards and what might happen, for example, after an operation, and also in the emergency department. So it is good as we debate how much of the opioid problem stems from hospitals versus how much it might stem from primary care.
So what
it's good, I think, to see the focus go to the hospitals.
So what needs to change that your standard is going to drive? What are the changes?
So one of the nice shifts, I think, is to inform patients more, so to get better information to the patient and that shared understanding of why a decision has been. I think that is always a good thing. Some other points are to put the onus on the initial prescriber of the opioids to talk through the likely trajectory with the patient, including how long the intended use is for and the process of stopping the opioid. So it's to avoid perhaps a vulnerable patient might meet vulnerable GP prescriber after discharge from hospital and that turning into long-term opioid prescription. This is very much getting on the front foot early and to say that this opioid might be appropriate for a few days after surgery, and then the plan is to stop it.
So now one of the issues are prescribing in too high doses and also giving people far too much drug to take home with them.
Yes, there has been at times in certain hospitals a default practice perhaps of giving a standard pack of endone 5 milligram tablets, 20 of those tablets to take home from the emergency department or the surgical ward, irrespective of how much they've been using or their pain intensity at the time. So this standard looks to dig into that a little and say that the amount given at discharge from hospital should be relevant to how much pain the person has and how much they've used in the last 24 hours if they've been on a hospital ward, for example.
Now, there's an epidemic of knee replacements going on in Australia and hip replacements. These are operations, particularly knee replacements, that are notorious for long-term pain. Now, if you start to say to people, well, we're going to really limit your opioids, you might get a set of panic going in. Do we manage pain properly? In other words, beyond just the opioids?
I think part of the focus of this report also is to look at the more multidisciplinary or multidimensional aspects of pain rather than just relying on the opioid. And I think the evidence is fairly clear that the opioids can play a helpful role, but are just one of a broad range of aspects to that. So particularly getting the right amount of physical loading of the tissues after the surgery, as well as addressing any psychological aspects that are going on, as well as in a small number of patients addressing other problems if there is a background of drug dependency or addiction in the picture, that needs to be managed via the appropriate pathways. But the emphasis of this clinical care standard was very much on providing good pain relief with safety. So it means just looking at the individual aspects of the patient's situation and adjusting treatment accordingly. So the desire is certainly not to remove good medication from a patient's treatment plan.
There's been debate about just how effective opioids are at pain relief, and that they're less effective than people might think. And sometimes a combination of paracetamol and ibuprofen can be just as effective. Do we overprescribe to start with and just assume that standard painkillers are not going to work?
I think there has been an element of that, and certainly part of this standard is to suggest multimodal from early, and also to suggest that opioids aren't always the default medication of first choice. So as you suggest, paracetamol and anti-inflammatories can be sufficient analgesic medication for many types of surgery, and especially if it's combined with setting the right expectations and the right amount and the right timing of physical activity post-operatively. In many situations, opioids may not be required at all, especially when you start to look at some of the downsides, like constipation is a big problem, I think, that can be nasty in the post-operation phase, and clouded thinking, which also can be not a good thing in that phase.
Just briefly, how are you going to monitor this? You set out a standard. How do you know if people are going to comply with it?
So this will eventually, I'm not quite sure the time frame of this actually, but the intention is this is eventually built into accreditation standards for hospital. I don't think that's happening in the next year or two as this is bedded down, so to speak.
So it's one of the things that the hospital will be judged on?
Yeah, there will be a number of indicators that have been listed in this standard that a hospital can be judged on by external accreditors. So hospitals will, over time, be required to report on a number of these indicators.
Chris, go back to panicking about climate change. Nice to speak to you.
Thanks, Norman. Good to chat. Bye.
Pain medicine specialist Dr. Chris Hayes, and we'll have a link to those standards on the Health Report's website.